Okay, so this is the Maple Room, and this is and the importance of research and data collection. So if you're in the wrong presentation, I'll close my eyes. you can, you can quietly leave. It's okay. I don't take offense to these things. I'll tell you why I chose this topic and why this became an important topic for me. Actually, when I started my doctoral degree, I was not into research at all. In fact, that's the last thing I wanted to do. But as interesting as it sounds now that I've completed and I'm been in practice for a while, licensed, data collection and research is something that I love absolutely. And I'll show you the data that we collect because you'll see how the impact that it has on us as a practice and our clients. So what do? I am the deputy director of Khalil Center, and Khalil Center initially started because in Chicagoland area there are pockets of Middle Eastern, South Asian Muslim populations that were not seeking help when they needed help. And primarily, I grew up in the post 9/11 culture here, so I understood the hesitancy. But the primary reason was because the lack of trust, that they didn't feel that if they went to somebody who didn't look like them, didn't speak the language, can I really trust this person? This is also around the time when there was a lot of FBI surveillance happening. So it's like, oh, if I tell this person my things, will they tell everybody else? I mean, they still have issues trusting us, confidentiality sometimes, and I'll tell you the data that we collected on that as well. But so Khalil Center started with that we want to make sure that we have a place where these individuals who need help would come and they would feel safe. Now, my friend who's the founder, when he approached me and we started this, the question that I always had was, okay, is this really necessary and is it working? And it was like always the question. And you cannot answer that question by your own self. And you cannot answer that question by asking one or two clients or your friend, because you always get the same response. Yeah, this is absolutely necessary. So, I turned to data and I said, okay, let's collect data and see if what we're doing is actually important, if it actually makes sense, and if it's actually needed and necessary and important. So that was back in 2014, I want to say 13, maybe even before that. Now, I mean, we've grown, and I'm happy to say Khalil Center is the largest provider of Muslim mental health in North America. We have offices in Chicago, California, New York, Toronto. We have international affiliations in Turkey, and next one in Pakistan. So, the part of that collaboration is to help individuals outside. So I did part of this presentation in Pakistan as well. And I'm actually doing the screen recording so I could share that with folks there, because that's also very important. I want them to understand the importance of research and data collection. And so one of the first questions that we asked our clients, because I wanted to know, do we need Khalil Center? Do we need a place like that? We asked 5 questions. So we started out with a very simple data collection. We used Google Forms. We had a signed BAA agreement with Google, so it was HIPAA compliant. The first question we asked at the time was, did you consider going to someone who was not a Muslim before coming to us? Just consider, like, where's your attitude at? And at that time, you can see the data trends. Where is it at? Okay, there we go. So at that time, it was about 41% people said that they considered going to somebody who was non-Muslim. But then the next question was, did you actually visit someone who was not a Muslim for your services? And 26% said they visited. So even though close to about half of them considered, but about 1/4 of them actually went because because of other reasons we'll talk about. So the third question was, how important is it that your therapist shares your cultural background? Because Khalil Center specializes heavily in spiritually integrated therapy. There's a lot of we don't proselytize, the client-centered, but the environment when you enter the office, you have to take off your shoes. We have calligraphy on the wall, so it's very much a spiritual place. So I wanted to know, is it the culture or is it really the religion that's making a difference here? So we asked, how important is it that your therapist shares your cultural background? And somewhat and extremely important, we got about 63% people to say that at that time. Then we asked, how important is it that your therapist shares your religious values? And about 96% at that time said somewhat or extremely important. And the last one was, how important is it that the spirituality is actually integrated into therapy process? And we got about 97% people to say that. So I was beginning to see that this is actually something that's important. And obviously the proof is in the pudding. We've grown, so we actually know out of our Lombard office, on average, we do about 150 to 200 sessions a week. And we have multiple clinicians, majority female, and our clients tend to be majority female as well. Another trend, which I found interesting, was when we first started out, only 25% were males. And generally in the population, you see that trend, which is like about 60-40, like 60 female, 40 males. So I wasn't surprised, but 25 was a little lower. Now I know growing up in my household, men, when they have problems, they're not likely to accept that. Middle Eastern, South Asian men, it's like a pride thing, And then if you go see a therapist, which for the most part tend to be women, that's another than like a blow on our egos, just to be honest with you. And so, but now the recent data collection that we did, that went up to 40%. So as we've grown, we've seen that come to a norm. And the questions that I stated earlier, the most recent data collection, which I'll share with you, now people are actually not only coming to us because of the religious or spirituality, it's because they actually want to come to us and they see us as professionals. So that same 96% that I shared with you earlier about therapists sharing the same religious values, or 97% that wanted the spirituality into therapy, that has gone down to about 88 and 89%. And that sounds like, oh, it's bad news, but it's good news for me, because now I can say that people who previously didn't care whether spirituality was part of it or not, or cared more, and were looking for specific those services, now we're getting people that are in all spectrum of spirituality, religiosity. We get people that are not even Muslim, it's open to everybody. We don't obviously we have people who come to us because we're cheap, it's just very affordable care that we provide. So, that's something that's, now all that came to light because of data. So, for me, if I have to present and if I make a claim, like Khalil Center is the largest provider of Muslim mental health services in North America, the next question will be, well, how do you know that, right? Because I know I've talked to other organizations who do the service. I asked them, how many people do you serve per year? For our educational prevention services, and this would be considered an educational service because I'm representing Khalil Center here as well. We serve about 36,000 people a year. So all over the U.S. and world, when we go for talks and then we do like Friday sermons and all sorts of things. So all that data is very good. Now, the other component, the other reason why I really went into data collection was I went to the Practice Leadership Conference in D.C. and I ran into one of the lawyers for APA, forgetting his name now, and he and I was telling him about my practice, and he said, have you spoken to insurance companies about getting a better reimbursement rate? I'm like, really? You could do that? I didn't know it was possible. He said, I can get you in touch with people, and then you have the conversation, see what happens. So I had a phone call with some higher uppers in Aetna, and they said, and I mean, I'm quoting, they said, if you can prove to us through data that your practice is actually helping individuals, that you are decreasing the number of hospital visits and ER visits, we will give you a significantly higher rate. Now, those are their words. So, but again, keyword is through data, right? That you can prove to us through data that so you can actually take the data, go to your insurance company and say, look, here's what I'm doing, here's what's working. The third thing was, for us was, we try to have a very holistic approach to healing, and we try to shy away from manualized therapy approach, although some of our interns and early clinicians, we do encourage that because they're still training. But one of the thing that we were wondering was like, is it working? What we're doing, is it working? And if it's working, how do we let people know about it? So we all know about evidence-based practice. Our goal was to do practice-based evidence. So this data collection actually goes into that as well. It's like our approach, is it working? How do we show that it's working? Is it helping individuals? How do we get those numbers to show them? So I'm going to talk a lot about ways that we can incorporate data collection into our practice. Obviously, I'm just going to do a little quick primer on what is data and why it's important. So obviously, data is any research, any piece of information that you collect, observe, generate, or create. Now, for us clinicians, some of the examples would be our documentation, our charts. It's all data. Our notes are data, qualitative data as well as quantitative data. If you're doing assessments as part of your treatment, which we all should be, we'll talk about that. Any questionnaires, any assessments that you give before, when people first come in and throughout the course of treatment, any contents of the form. So I'll share with you the data at Khalil Center in a minute. And you'll see that even small pieces of information actually matter and are very important, especially for us. We're a nonprofit institute, so when we present to our grantors and people who are donating to us, speaking on our finances, as I said earlier, we're very affordable, so people come to us. We don't turn anybody away. We have a strict policy of service over fees. So everybody who comes in will get the same treatment no matter what. And the way we recover from that is through grants and donations. So when we go to our grantors and we go to the community, we let them know through data that this is what we do, and a lot of that comes from the contents of the forms as well. Any methodologies, procedures, any approaches that we implement into practice as psychologists, that's still considered data. So why data? Well, we know through at least Medicare and some other insurance companies. I know United Healthcare, and I think this is a trend that's going to continue on with all insurance companies in the future, that they look at outcomes to determine reimbursement rates. So the way I'm seeing it, and I've had the conversation with insurance companies heads, it was basically, if you can prove to us, then we'll give you a higher rate. But the way I'm predicting it, if I had to put my money on, I would say that in 10, 15 years, it'll be like, if you don't show any data, you'll get this rate. But if you do show data, then you'll get a higher rate. So it's always a good idea to incorporate that, as we're continuing on. Whether you see Medicare patients, we don't see Medicare clients. We have some, but I'm not a clinician in Medicare yet. It also helps us to determine the course of action. If your treatment is not working and the data shows it, then you have to modify it. I mean, if something's not working, you got to figure out what's going on. Maybe the approach is not, maybe your data collection approach needs to be changed. Maybe you're asking the wrong questions. But if, for like our marital clients, and we use a system called REDCap, and I will show that to you as well. For our marital clients, we do marital satisfaction data. And so I've had, recently a couple where, I asked them, because it's a common question that we should ask, and I make it a habit, is how are we doing so far? We've had 8 sessions or whatever. Has it been helpful? What has worked? What has not worked? And I had the husband say, it's the same. Like, I feel like nothing has changed. And so I was like, okay, well, let's look at the data. So we looked at the data. When they first came in, marital satisfaction was here. And then, after 4 sessions, it was here. And after 8 sessions, it's here. So I'm saying, okay, there is a change here. There's a significant change here. You might not feel it because maybe you're in a bad mood or, whatever's going on. But the fact is that according to your own report, your satisfaction in your marriage has increased over the last 8 sessions. There was no response to that from him, right? It was kind of like this cognitive, issue, like, oh my God, like really, why am I not seeing it then, right? So, so it helps, modify treatment as needed. Clinicians become more self-informed. Like I said, is your intervention actually working? And should you do something different? And then the client is informed. And there's a ton of research, and I'll present some, that talks about that just clients knowing that things working or just doing the assessment again, every few sessions helps them heal. There's something about that process. It's like this awareness that comes in. And I've had clients who come in and say, oh, I remember checking this at 4 and now it's at 0. And I was really surprised because when I first came in, that kind of, shook me, because sometimes clients, especially those that come from, like Middle East and South Asia, they're not aware of a lot of psychological symptoms. We see a lot of somatic issues because anxiety isn't presented with the same symptoms that people have in the West. You have like back pains and headaches and stomach problems. And so the question like that is asked, and they're like, oh, I didn't know that there was a correlation. And then now, I don't have that issue anymore. So just that, that insight is actually very, very helpful. And that helps, like I said, with the clients as well, and the clients end up saving money as well, and clinicians can make more if they do it right as well. So the data that we already collect, most of it, the reason it's not the best type of data is because it's mostly qualitative, it's anecdotal, and non-experimental observations. It's not tidy, it has to be cleaned up. And sometimes it's hard to present it as evidence. And I'll tell you the different levels of evidence and why that's the case. One recommendation I would make is that if you have a practice that's a little bit bigger, and even if you're a sole practitioner, take interns. You'd be surprised how many bachelor level, master level interns would be interested in coming. And if you get a bachelor level intern and someone that you can train, so we have bachelor level interns at Khalil Center, and we train them on how to handle data, make sure that they understand that this is a very, this piece of information is very valuable and they have to handle it very carefully. They do a lot of this work for us sometimes. So like I even, for example, the number of sessions per clinician, on average, which office is doing more sessions, on average, which clinician ends up having more sessions with the clients. So there's one clinician who's having, say, an average of 8 to 12 sessions, which is our average is about, I think, 8 or 9, or maybe 10. It'll come up. And then there's one clinician that averages like 4 sessions. So then I have a conversation, not to kind of like pressure them, but just to see, hey, what's going on. Like maybe they need some support, some guidance, mentorship, trainings, whatever it is. It's not for like, you're going to be fired if you don't get to like average of 8. But that kind of data, I have a intern that collects that for me. Right? So if you are able to handle that, you just need to put yourself out there, talk to schools. Some people are already affiliated with academic institutions. Get some interns. That can be really, really helpful, especially when it comes to tidying up that data. So when it comes to levels of evidence, that's very hard to read. Even for me, it's hard to read because once you connect that projector, it messes this up. But what you have here at the bottom, and I'll read this to you, and we're talking about quality of evidence, so the lowest quality versus the highest quality on top. You have background information, expert opinion, and data that's not based on guidelines. Then you have individual care reports, you have case studies, you have cohort studies, non-randomized control trials here, randomized control trials, critically appraised literature, evidence-based practice guidelines, systematic reviews, and meta-analyses on top. So the higher you can get on this in terms of providing that evidence, especially if you want to show evidence in terms of like what I'm doing is actually working, then we have to aim for the highest one. We are actually part of a big data study right now, which ends in December, funded by the Templeton Foundation, and this is a study where there's multiple sites. I want to say there's like 20 some sites, I think. A lot of Christian with different denominations, a couple of Jewish sites. There's only one big Muslim site, and there's a smaller one. And the idea is to see if spiritually integrated therapy actually works. So there's a conference happening in March 2020 in North Carolina where all this data is going to be presented. That we are part of some of these higher quality evidence as well. But I'll show you the internal data that we collect as well. This just kind of goes over. Wow, this is really bad. Different levels of evidence, and so at the very low end, you have descriptive data, and then these different columns that we're looking at here. Parameters, evidence, types of research, and the effectiveness of the interventions if you present that data. So descriptive data, we have intervention like goals, target groups, methods, activities, requirements, and these could be descriptive studies, observational studies, analysis of different documents that you already have in the office or in your charts, and then interviews. And there's some potential there when it comes to effectiveness of intervention. And then when we move up, we also, when we have theoretical evidence, we're talking about plausible rationale that exists in there to explain why something will work with specific individuals. And I think we're kind of, for Khalil Center, we're between number 2 and number 3 here. And this includes reviews, some meta-analyses as well, expert knowledge studies, and like I said, it's plausible data. Then there's indicative evidence. Now this also has a component of intervention that clearly leads to some kind of desired outcome. So when we do outcome measures, and we'll spend a lot of time on that today, is that actually helping? So if you give a BDI in the beginning and you work with somebody who's depressed, and then you give a BDI at the end of your treatment or after X number of sessions, did the symptoms actually decrease? And these type of studies can be quasi-experimental, theory of change studies, benchmark studies, quality assurance studies. Like I said, even with knowing how many sessions each clinician is doing. And then the best would be if you can establish a causal relationship, and that you would have to have substantial evidence that the outcome is actually caused by the intervention, and a clear evidence that shows that the ingredients of the intervention are responsible for the outcome. That's a very difficult for us solo practitioners and where we are, but that's the target, right? That's the ideal that we want to achieve. So randomized controlled studies, and that would be the most efficacious type of data. So for us as clinicians, the way I see it, there's We either have administrative records or we have that which we ask our respondents. We have data now. For us, it's mainly service-based data. But if you were to, and we have at the Khalil Center, one of the things that we've done is like when we do our marital workshops, we will ask certain similar questions to those that come from the community. So this is more like population-based data versus that which was more like service-based data. Or we'll go out to the mosques sometimes and we'll give out surveys, or through social media we'll give out surveys, just to kind of see where the community is at versus where the people that are coming to us are at. Again, that requires a lot of work. One thing I'm going to say is that I know this. We'll talk about barriers. It sounds like it's a lot, and it is in the beginning, right? When you first start out, because you're getting used to this process of data collection, you're implementing maybe new systems. You might have to get like some type of equipment installed in your office, or if you're using cloud computing, you might need to get like a tablet or something. But once you have it going, once it's like a process, it's a lot easier and a lot simpler. In fact, for us, it made our life easier, and I'll show you how we collect data right from the beginning of when somebody contacts us. So outcome data, we're looking at outcome of our interventions, and I said before, Medicare, Medicaid, merit-based incentive payment system program. Other insurances will definitely follow through. Some already asked for some data. I've had United Healthcare asking me to assess my clients, for insurance purposes as well. And we said patients will do better. So barriers-wise, the first barrier typically is, like what do I do? How do I start? What's the best place? I don't know what to do. Practice Ground is a really good place. It's an online community. It's for clinicians. It's made by the clinicians. And trainers and researchers, and basically the goal is to improve patient outcomes. I believe now. I know I'm from nonprofit, also through academic affiliations. I end up getting a lot of free stuff, So I do think this one is free, but I could be wrong. But I know that they do have a huge community, and if you have any affiliations, this is a kind of a side thing. Like when it comes to research, a lot of times people are like, I don't have access to articles, journals. If you try to download one, they ask for money. If you go to your local library, which you pay taxes to, they will have access to that journal. I live in DuPage County, so College of DuPage has an online system where I can sit from my home, log in through my library, and access thousands of journals. Right? So it's free because I pay taxes, and I have a card at the library. My local library has access to magazines. Which I can get electronically without any kind of payment on my end. So a lot of times this is like people don't really know, but if you have any kind of academic affiliations, if you have a community college, you get a library card, you might be able to. The other thing is this integration of technology. Now technology can be a little bit challenging, but the analogy that I like to give is if you want to go skydiving, right? Until you actually go skydiving and try it, you're not going to be 100% comfortable. No one who's not done skydiving can stand here and say, oh, it's easy. Like I can do it, right? You might feel that way like for a little bit, but like after a few minutes, you're like, yeah, I don't know about that, Or once you start making plans and start seeing videos, like, yeah, this doesn't sound right. And so it's the same way with technology. Once you take that leap of faith, it gets a lot easier. And the beautiful thing about technology is that a lot of the nerds like me are putting up videos online on YouTube. So if you're not sure, like how do I connect my router to my modem, or what is a router, what is a modem, you just put it in YouTube and you'll find somebody who explains it very nicely and very beautifully. I recently upgraded a system at the Khalil Center for security reasons, and I wasn't sure, and we ended up investing about $700, but it was worth it. It's a very strong firewall, uses some kind of cloud key management. And I didn't know how to connect all that, and I went online and some guy had like A to Z how to set it up, explains everything in the small detail. This is what this setting means. Here's what you do here. If you do a guest network, here's how to set limits on downloads, and here's how to make sure they don't access your local network. It was really, really easy. So do that, because I don't have any degree in technology. It's all been through interest, and I think if you're looking for something, you'll find it. The other barrier typically is the clients following through or following up. And this is where we actually use our admins and our clinicians as well. So we don't use high-end, you don't need iPads, it's nice. Like my iPad, it's very expensive. So you don't need to invest that much. You can get a $100 Android tablet from Black Friday sale. The concept is very similar. If it's up-to-date, tablet, if you're using a secure web browser, secure system, It doesn't matter whether you access it through an iPad or through an Android tablet or through an old laptop. It works the same way. So we ask our admins, our clinicians, to give these tablets to the clients when they first come in. So they come in, they're in the waiting area. Can you please fill this up? It's been 4 sessions. So they fill up the data. And because we're doing the other study as well, the big data project, so that's a separate component if clients are part of that as well. And then we actually tell the clinicians, look, if they fill up the data, you should go over that with them before the session, right? Or when you begin the session, the first 5-10 minutes, go over what they just responded to. Share with them, okay, before your symptoms were here, now they're here. It's a really good practice, and it kind of becomes like this process which is very seamless. So that for us covers up the clients following through. The initial data is actually already electronic. That's what I'm trying to say. If you're trying to apply for grants or present this data to funders, it will help. In terms of how clients improve, so there's just some data that I pulled up just to kind of show, some meta-analyses done recently as well. So Fortney and others looked at 51 randomized control trials. Almost all that consistently collected data showed significant improvements in outcomes. A one-time screening was less effective. Most clinicians, I think, will do one-time screenings, because it's something that they feel it's easier. I just want to see where you're at. And then usually they either forget or, it's not easy to continue on with ongoing screenings. Measurement-based care outperformed usual care, and there was decreased cost and lower likelihood of patient deterioration while they were in treatment if the clinician was collecting data. So again, I don't serve Medicare clients, but I do have some information on MIPS and how the Center for Medicare and Medicaid Services is moving towards that, and other insurances will as well. Currently, psychologists have to participate if in any given year they treat more than 200 Medicare beneficiaries, they bill Medicare for more than $90,000 in allowed charges, or they provide more than 200 covered professional services. Other psychologists can participate if they meet any of the above requirements, and there's an incentive to that as well. So we're going to spend a lot of time on outcome measures because I want to make sure I give you some ways that you can collect data so that it could be more practical and more useful. Perhaps the easiest and the cheapest way is to use the DSM-5 assessments. And I say that because you don't have to worry about copyright issues. They're there at the end of the DSM. They're available free on psychiatry.org, I believe is the site. And all you have to do is go ahead and print them out. And what they have are these level 1, level 2, and on measures. So level 1 is you have the symptom measure, which is self-rated for adults, parent, guardian rated for children 6 to 17, and also self-rated for children 11 through 17. And this picture on the right is a glimpse of that. So it kind of gives a general outline of how they're doing with several different areas, symptoms, depression, anxiety, OCD, etc. And then you have level 2 cross-cutting symptom measures for depression, anger, mania, anxiety, ADHD, substance use, and others. Again, these are all available for free, whether in the back of the DSM if you want to make copies from there, or if you want to get it from online from psychiatry.org. Screening inventories. Now, there is some research debate, and we're not going to go into that debate whether screening inventories are good for outcome measures or not. They're just the easiest to use, and most people use them anyway when people first come in. I'm sure a lot of you have used the Beck Depression Inventory, Anxiety Inventory. It's very common. The most commonly used that I've found in research is the PHQ-9 and the GAD-7. So again, it's measuring the patient health questionnaire, and GAD-7 are measuring depression and anxiety symptoms. Also in that frequent use, we have the PTSD checklist, and I'll go over all of them. Alcohol use disorder identification test, which is audit. The Beck Depression Inventories as well, BDI and BAI, the Hamilton scales, the HAM-A for anxiety, the HAM-D for depression, and then the Hospital Anxiety and Depression Scale, which is one that's been there for a long time. And even though it's called the Hospital Anxiety and Depression Scale, it can be used in primary care settings as well as on the general population. So we'll go over all of them one by one. So PHQ-9, very frequently used. It's probably one of the easiest to score. It's only 9 questions and track as well. Very reliable, very valid assessment. Internal consistency reliability, 0.89. Inter-rater reliability of 0.94. I mean, this is like very, very good scale. It can predict, has a very good positive and negative predictive value as well. sensitivity, specificity. So we're talking about making sure that there's true positives and true negatives that are being picked up by these scales. So if somebody has depression, it picks it up. Somebody doesn't have depression, it also picks it up. And then you have the GAD-7, the GAD-7, also very frequently used, also very easy to score and track. This picture that I took this from is actually from one pager. So on top you have the PHQ-9, and at the bottom you have the GAD-7. So it's on one page. People fill it up. You can combine the scores too if that helps, right? If you just want to see an overall. We don't use that there. Actually, one of our psychiatrists likes to use that. So he's the only person at the clinical center that actually uses these two. The rest of us use BSI for our outcome measure. Again, very highly sensitive, 89% sensitivity, 82% specificity, very reliable, 0.85 for both males and females. Then you have the PTSD checklist, and I think the earlier versions had three. Yeah, the PCL for DSM-4 had three versions: military, civilian, and specific. This one, the PCL-5 is the latest one. It's only one 20-item questionnaire. It basically is picking up the DSM criteria for PTSD, 0 to 4 self-report scale for each of the symptoms. Again, highly reliable and valid. Internal consistency 0.94 to 0.97. Retest reliability. Usually these are done. See, this one's like 2 to 3 days. It was still reliable at 0.96. A 0.88 at 1 week. Meaning, if they took it again, it was still picking it up without any kind of issues related to its reliability, and highly sensitive and specific as well. So very good for PTSD. The audit, which is the alcohol use disorder identification test, that's if you do work with people who have alcohol issues. It was developed by the World Health Organization, again, to identify risky, harmful alcohol consumptions, as well as dependence and abuse. It's only 10 items, looks at the amount and the frequency of alcohol intake, and I'll show you pictures of it, alcohol dependence, and the problems related to alcohol consumption. Scores go from 0 to 40, and anything above 8 is considered harmful or hazardous. Highly specific and sensitive as well. Test reliability was also high. This is what this looks like. So you have the interview version on the left, and then you have the self-report version on the middle here. And this kind of gives an idea of when they're answering questions like what is considered how much when it comes to alcohol consumption. So a lot of these are very easy to use. BDI, I'm sure I don't need to tell you, but this is something that is also very frequently used. It's as old as Aaron Beck himself, and so it's pretty reliable. There's a lot of studies that talk about it. 4-point scale from 0 to 3 has a very high reliability and test-retest and iterator reliability as well, and consistency within the items. And along with that, people typically use the Beck anxiety scale. So again, 21 items. And some of these, like I said, especially when it comes to cultural, there is a lot of data to show that it can be very helpful in other cultures as well. I know from my cultural background, we usually ask more questions than here, even though it does talk about a lot of the physical somatic symptoms as well. And people rate how much of these symptoms have bothered them from, you score 0 for not at all and 3 for if it's severely, and the maximum score of 63. Again, high reliability, high validity as well. And then this is the Hamilton A scale, the HAM-A, which is the anxiety scale, 14 items. It's looking at both psychic anxiety, which would be mental agitation, psychological distress, as well as somatic anxiety, physical complaints related to anxiety. It's also a very good scale. We don't use this, but it is a good one. Then you have the HAM-D, which is for depression. Again, 21 items. The scoring is only based on the first 17 items. Doesn't take too long. 8 items are scored on a 5-point scale. 9 are scored on 2-point scale. Again, high sensitivity and specificity when you talk about the cutoff score for depression. This is the hospital anxiety and depression scale. It, again, measures both anxiety and depression, so you see the D and the A here. I'm sorry about the quality of this. I think this is the projector, but The depressions question and the anxiety questions are asked simultaneously. 7 questions for anxiety, 7 for depression. Again, highly specific, sensitive for both anxiety and depression. Then we're going to talk about well-being and quality of life scales. These are also used as outcome measures. So the WHO-5, which is the well-being index, only 5 questions, 6-point Likert scale. It's based on positive mood, vitality, general interest. This one's been translated into 31 languages. So if you have individuals, and this one's available online for free. There's also the short form health survey, 36. Now this one is used by Optum and Medicare. It has 8 sections: vitality, physical functioning, bodily pain, general health perceptions, physical role. If you need a copy of these slides, please email me. I'll gladly send it out, just to save you some time and phone memory. Emotional role functioning, social role functioning, and mental health. So also a good one. This is the one that we use at the Khalil Center, brief symptom inventory. I chose this after going through all of these, basically. The reason I chose it was because it was very easy to administer. It was very easy to complete for people. This is a shorter version of the SCL 90, the Symptom Checklist 90. It's 53 items. It's looking at 9 dimensions. So somatization, obsessive compulsive, interpersonal sensitivity, depression, anxiety, hostility, phobic anxiety, paranoid ideation, and psychoticism. Now, what we use to measure outcome, so those we use only if it's like a person we need to see where they're say like OCD symptoms, for example. But what we use for general and for everybody is the GSI, which is the Global Severity Index. So it starts from like 30s and it goes up to the 80s, the highest you can get on that. And anything above 63 is in the clinical range. Interesting note, when I first started out the Khalil Center, remember how I said that people needed help but they weren't getting help? Those who were coming in were scoring in the clinical range, right? So they should have gotten help, but they didn't go because the person wasn't speaking their language and looked like them. So now that also was really helpful in talking to our donors, because like, look, if you're funding it, there's a reason these people need help. They're not seeking help. Here's our data to prove that. It's very reliable, very valid, and it's something that I will actually show you right now. These are the 53 questions in the last 2 weeks. How distressed have you been from 0 to 4? And then you get the average of them. So, add them up and divide by 53. And then they have tables for adult males, adult females, children, so you have to get the scale score from that. So it has a lot of data that the norming data that's available for us to use as well. Talk about some recommendations. So I would say that the first thing, the easiest thing you can do is, for intakes especially, use some kind of a software solution. If you, for example, you can use Google Docs if you sign a HIPAA Business Associate Amendment with them. You can, they have a Google G Suite, which is specifically for organizations. If you're a nonprofit, if you're an educational institute, you can get it for free as well. We have it for free. REDCap, we also got it because we're a nonprofit and we collect data. Then there's the PROMIS system, Patient-Reported Outcome Measurement Information System. We don't use this. Actually, coincidentally, as I was working on this presentation, the APA Monitor on Psychology came out with an article that talked about this. So I pulled some of this from that as well. So this is funded by the National Institutes of Health. It provides clinicians, researchers, reliable, valid, flexible measures. And it's a computer adaptive test so that you don't have to give a longer test if you can measure the same symptoms in a shorter version. So it determines that for you. There's also the Partners for Change Outcome Management System and the OQ Analyst. It's all web-based. I think this is stuff that you have to pay. Provides real-time clinician and client reports, includes early warning treatment failure alerts as well. There's patient registries, APA's Mental and Behavioral Health Registry, the other APA, the American Psychiatric Association's PsychPro. There's FIG-MD, there's the Patient-Centered Outcomes Research Institutes, PCORNets. They have a digital network of electronic health records and claim data across healthcare institutions as well. So that's the end of my presentation. These are the references. If there's any questions.